because we're used to working in settings where resources are difficult to get. So yeah, so that was very interesting. I want to show you guys a video, but before I do, I just want to talk a little bit about our specific approach in New York. So we, knowing that we didn't have hundreds of doctors and nurses to offer New York City, we said, okay, where could we fit in? And we really, New York is a place that has, I'm sorry if you hear a lot of screeching in the back, there's construction going on outside my apartment. So apologies for that. So we, New York City has a lot of amazing organizations that are very, have been working for decades in this community. And so we really tried to plug in with existing organizations and see where we could help them and where there were gaps. And most of the gaps we found very quickly were among vulnerable and at-risk populations, and notably the homeless and people who are what we call housing insecure. So people who are kind of on that line between, being on the street or staying in whatever housing and home they have, because everybody was told, stay home. Where are the homeless supposed to go? If you've lost your job and you can't pay rent anymore and you've lost your house, where are you supposed to go? How are you supposed to isolate? So I want to show you this video that highlights the work of one of our partners, Coalition for the Homeless. Give me 1 second and I will share my screen. And computer sound. Sorry, 1 second.
Look, if there's anything that we've learned from this whole period that we've been through with the COVID crisis, it is that housing is healthcare. What we did see in the context of an outbreak is that allowing people to live out on the streets, to not have a toilet, to not have a place to take a shower, it's not just an affront to human dignity, but it is actually a threat to human well-being and to human life.
While COVID-19 was picking up steam, we did have quite a bit of people who say, no way in heck am I going into a shelter, knowing that this is where, you're in a setting with a lot of other people. You have no real privacy. You have no real boundaries. They're not keeping the 6 feet distancing. And there are many reasons why people do not want to stay in shelters. Usually the biggest is that they've had a negative experience in the shelter system. They've expressed sometimes being robbed, a lot of drug usage, not good stuff happening inside the shelters. So they rather take their chances in staying outside.
The pandemic presented some real challenges for how we operate. There were so many newly homeless people that there was a big surge in need on the streets. So we just had to ramp up those operations very quickly. We really would not have been able to do so without the help of Doctors Without Borders, because there were so many needs that we weren't prepared on our own to meet, like the need for showers and toilets and PPE. We have more homeless people in New York City now than at any time since the Great Depression. There are thousands of people on the streets tonight. There are 62,000 people roughly in the shelter system. There's 20 times that many that are living in unstable housing, just teetering on the verge of homelessness. When you get something like a pandemic and then the economic crisis that arose from it hitting New York City, that's shaking a lot more people out of the tenuous hold that they had on stability, and they're ending up on the streets.
The people that we serve in our program are folks who may be working but may not have enough money to pay their rents. They're people who are out on the streets, street homeless as we would call them.
I can sleep in a shelter, right? I sleep in the street. I got my blanket, sleeping, I'm fried, sleeping, that's it.
There are deep systemic problems. Homelessness disproportionately affects people of color. Roughly 86% of those in the shelter system are Black or Latinx, while it's about 53% of the general population of New York City. There are a lot of reasons behind that, getting back to redlining back through the 60s and 70s, of predatory lending, by people in the real estate industry, by source of income discrimination. There are all kinds of mechanisms by which racism is used as a filter to determine who gets the resources and who doesn't. We don't want to go back to normal. Normal was terrible. It's not an answer to homelessness to warehouse people in shelters, to warehouse people in prisons, to warehouse people in overcrowded housing, or to let people live and die on the streets. Our only hope now is that seeing how this is played out adds more fuel to the fire to solve these problems on a systemic level.
Stop share. So that really highlights, the work of one of the really great organizations that we are able to partner with here, Coalition for the Homeless. And we were connected to them pretty early on, and they, told us, hey, what does the homeless? Oops. Can you hear me? Okay, hopefully. We asked them, where are the gaps for the homeless people in the midst of the pandemic? And one of the very early needs that was identified was toilets and hygiene facilities. As the video alluded to, we ended up opening showers here in New York City for mostly street homeless were coming, but it was also people who, as you saw in the video, not everybody didn't have a job, not everybody. It was people who really lost their access to normal facilities that, most of us take for granted, right? And it's a problem that predated the pandemic, but with everything that shut down, it just became an even bigger issue. So let me show you some pictures from the shower facility that we set up. Okay, the technology and me, we're not getting along well today. I apologize. I'm usually more adept at this. That's okay. I think after all this time doing Zoom over these last months, yeah, so we reached out to a bunch of different shower trailer companies. We looked at, could we do it in an existing space inside? And that proved to be really difficult because everything was really shut down. And, we looked at, could we open a gym or do something like that? And it just wasn't going to work because everyone was too nervous with the shutdown and everything. So we contacted I think more than 70 companies that do toilets and showers and stuff all over the country just to see what would be possible. And thankfully we found a company that was willing to donate the use of their shower trailer, which was amazing because a lot of these trailers and porta potties and stuff like that were being taken up by hospitals who really needed them, of course. The prices were shooting up because suddenly there was huge demand for these things. But they agreed to donate a trailer and later a second one because we opened a second site. And it ended up being better because we could do it outside and then people could more easily socially distance. It was a safer space for people. We had this shower trailer and, we would have people sit in these, different chairs and get themselves ready and then go into the shower trailer, take a shower. But during this whole time, we would be able to really talk to them. And for some people, this might, people had much more limited human interaction. So it was also like a support for people just to sit and talk and how are you doing? Are you able to get food to eat? We had a lot of information of other resources. If people were displaying symptoms or were sick, we were able to refer them on where they could go because we connected to the other organizations working in the city. And we were really just able to kind of keep an eye and a pulse on what was going on with the homeless population. Coalition for the Homeless has a soup kitchen a couple blocks away, well, more than a couple blocks, but kind of on the other side, on the east side of the city. And we were more on the west side of the city. And so kind of between both of us, we're able to really check in and see how people were doing. And then as well, give people hygiene items because people, when you're living out on the street, the more items you have, that can make you more of a target for people to come steal things from you, or people that you have to carry around whatever your items are. So people had limited things. There were obviously stores weren't open, services weren't open, so people didn't have access to that. One of the other big issues that we saw was the lack of access to healthcare services. Like there in New York City, normally there's huge needs in New York City, but there are also a lot of actors here. It doesn't solve all the problems. There are tons of underlying issues, which is one of the reasons why there are so many vulnerable people and so many actors trying to solve problems. But the healthcare in New York City has been a long-standing issue. And though more and more people have access to health insurance, the quality of that health insurance really differs between people. So you have a lot of people who depend on emergency rooms and urgent cares for management of chronic diseases, for example. And we know that people who have underlying conditions are at higher risk for complications if they are to contract COVID-19. So we really, we looked at that to see, what could we do? Should we set up a telemedicine platform, or how can this best work? And what we realized is that actually the biggest barrier for people wasn't necessarily that the services didn't exist. It was that they didn't have access to the services, because people were used to being able to drop in person to places that now had limited hours, or they were closed completely, or you're being told, don't go to the emergency rooms. The emergency rooms are too busy. So if you need help with your diabetes treatment, don't come to the emergency room. So where were people supposed to go? If you lost your job, if you had very little money, how are you supposed to, pay for a cell phone? How are you supposed to have a computer? Where are you supposed to get internet connection? So one of the other big requests that we got from many of the other organizations was to distribute cell phones, or to give people access to cell phones. So again, this is something we were able to do. I'll show you a picture of the team assembling the cell phones. Sorry, I really am usually much better at this, I promise.
You're doing great.
There we go. Man, Zoom and I are not getting along today. So we were able to assemble and distribute more than 1,000 cell phones. And we did this through other organizations in the city, which was really important. And I keep saying we worked with other organizations because we knew that we were not going to come and have a permanent presence in New York City. We were here really to be a gap filler, to help people kind of get over this most difficult time of COVID, and not to try to duplicate, we're Doctors Without Borders, we're going to come in and save everything. Like, these people have been doing this for decades. Like, they know this context much better than we do. And this is true in many places where we work around the world. I mean, of all the projects, I think this was maybe my 12th assignment or something with Doctors Without Borders. And I think in most cases, there are other actors, be it a Ministry of Health or other organizations that are also present there, and we never want to come in and duplicate services, but really try to see where our added value is and how we can also, augment or really help to support the work of these actors, and especially actors who are going to be there long after we've left. That was another aspect of our program. And then one big thing that was not as photographable, so I don't have great photographs of this, is that we did a lot of infection and prevention and control support, especially for supportive housing facilities. So these are facilities and organizations that support people who primarily were formerly homeless, and then were able to get into programs to get off the streets and to get into some kind of housing where it's subsidized, and into programs if they have substance abuse issues, people have mental health issues, things like this. So, to be able to support these people. But a lot of these buildings are congregate living facilities. So people have shared bathrooms or shared kitchens. A lot of times they have their own room, but the other spaces are shared. And, it's New York City. A lot of the buildings are really old. It's small hallways. There's not a lot of ventilation. So this is like potentially COVID breeding ground, and really dangerous for this population, often an older population. And like I said, a population that's at high risk, people who have a lot of underlying conditions, who have a lot of health issues. So, an outbreak happening in a supportive housing facility can be really dangerous. So we worked with, around 80 organizations on, you know, how they were set up to keep their staff safe, to keep their residents safe, because these were all essential workers. These were people who continued to go to work throughout the pandemic and the shutdown in New York. And people were nervous, and residents were nervous, and you know, they weren't sure what to do. So it was anything from, in these pictures you can see they're setting up these makeshift hand washing stations that we built, which are very similar to hand washing stations that, you know, last year I was in Congo working in the Ebola outbreak, and you would see hand washing stations like this everywhere. And, you know, we didn't have access to fancy hand washing stations during the outbreak or during the height of the outbreak in New York, because there just weren't, the supply wasn't there. So we had to really improvise. We had a jerry can and a bucket, and it was like camping in the lobby of these buildings. And then lastly, we supported a testing facility in Brownsville, Brooklyn, which is one of the most underserved communities in New York. It's, you know, something like 90% Black and Latinx population that live there. They're, you know, they have high prevalence of chronic diseases. You know, even things like the quality of food that people have access to is very low. There's a lot of poverty. So we got connected to a clinic there, and they had set up a testing site, and we were supporting them. We're still providing them with some support as they're trying to figure out the best way to kind of both do health promotion in the community and really encourage people to, you know, practice social distancing, wash your hands, wear the mask, do all the things that we're supposed to do, but also to get tested and how to get tested and how to get treatment and how to get access to medical care. So that was our New York program. That's it. Thank you for listening. I think Allison is going to give also some information on some of the other programs that we did in the US. So I'll turn it over to Allison.
Great. Thank you so much, Michelle. Oh, I see Elizabeth clapping. Thank you. Maybe before we go on, do you have any questions specifically to the New York City project for Michelle? So if you do, you can unmute yourself and ask your question.
Are these projects still going on? What's happening there in New York right now?
That's a great question. I should have said that. So as New York opened up, more and more services became available. So we closed the New York project at the beginning of July. The shower program, we were actually able to hand over to another local organization. We ended up with 2 showers, one in Midtown Manhattan and one in Harlem. And the Midtown Manhattan one we did in the parking lot of a Salvation Army, and they needed their parking lot back. So that one couldn't continue. But we did the second one in the parking lot of another Salvation Army in Harlem, and they were able to keep letting us use their parking lot. So we were able to hand the showers over to an organization called Shower Power, which, you know, is a local organization. They've actually been trying to open up showers for years, and New York City is really difficult to get anything going. There's lots of red tape, so they were really lost in the red tape, but used the momentum of the open doors that we were able to get in COVID and kind of rode the wave and took over the showers. So it was really great to hand over to them. And then the other programs were less needed, you know, really in the height of the crisis. People really needed the infection prevention control support, needed the phones, all of that. But now that things are a little bit more in place, people have more access to services now, that's been less necessary. So we were able to kind of very confidently close the program, but we're still in touch with a lot of the people that we were working with and continuing to monitor the situation.
That's just so wonderful what you have done. Thank you so much for sharing that.
Thank you.
I have a question. What other known organizations were you working with, just out of curiosity?
So we worked with the Supportive Housing Network of New York, and they are like kind of an umbrella organization for lots of different supportive housing organizations. So I'm not going to be able to name all of them, but like the West Side Federation for Senior Supportive Housing, Project Find, Housing Services Incorporated, Yeah, organizations like this. I'm like, it's like since the beginning of July, so I'm forgetting don't have all the names right at the top of my head. We worked with New York City Relief, which also does a lot of work with the homeless population. Salvation Army partnered with us to do the showers as well and to help support that. And then the Brownsville Multi-Service Family Health Center was the health center that we worked with in Brownsville. Yeah, that's, yeah, a lot. Like, I mean, it was really great. Like, it was a really nice, like, collaboration. Like, people were, I mean, these organizations are doing amazing. They're in the trenches every day, and we just jumped in for a couple of months to help. But it was such a beautiful, like, everyone was just rolling up their sleeves and let's do this and let's see, you know, how much we can do and be creative. And yeah, it was very inspiring for me to be part of that in my own city. That was really very special.
So if things get worse again, will you go back or reopen some of the things that you were doing there?
Great question. It's hard to know. I think we would be in a similar dilemma in many other contexts as well, that where we leave or we close activities or projects. I think it will depend on you know, what the issues are, what the support is that's needed, and what our capacity is. Because also for us, we don't have unlimited resources, so we always have to make choices between where we go and where the priorities are. So we definitely, you know, keep a good connection with the different actors we were working with, so that if there were needs in the future, you know, they can be in touch with us and we can see how we can support. I know for some of the other projects that have closed that Allison will talk about, we've, you know, stayed in contact with a lot of the other organizations that we've worked with there as well, just to check in and see, you know, if there are ways that we can help. Yeah, so we'll see. We'll see how it evolves.
Thank you.
Hi. Kathy Demont. Yeah, Kathy Demont speaking. Thank you for taking the time to come and talk specifically to World Wings. Given that COVID is all across the world, who determines where the need is greatest? Do you have a central committee that says, oh, look at the occurrence of COVID in Italy, or, oh, look at it in Hong Kong, we should go there? How do you prioritize all these COVID occurrences?
Also a great question. So we have 5 main operational centers who are responsible for all the operations that we do around the world, and the 5 of them coordinate with each other about, you know, who's going where and who's doing what. And there's a lot of division of geographical areas where people are focal point here or there. But we also, you know, because we have been, you know, working around the world for so many years, and we have a lot of relationships already, we, you know, have that advantage of being able to keep on top of what's happening. And we have an envelope of money, basically, that for emergencies and for responding to emergencies. And each one of the 5 operational centers has their own envelope, and they make their own autonomous decisions, but within coordination with the 5 of them. And trying to divide and conquer, so to speak, a little bit there. So it's a very collaborative system, but there are people, I mean, you know, like when I was working in the Amsterdam office, and it's similar in the other operational centers, that, you know, there's a team that is fully dedicated to this. Like, they are monitoring emergencies, they are constantly in discussion with other actors that also do emergency response, and, you know, who's going where, who's doing what, not just Doctors Without Borders, but other actors as well, and where do we have added value, and where will we be most useful. So it's not there's no recipe for it, but it comes from, you know, a lot of really experienced people who have quite a lot of training experience in all of this, and staying connected with other actors and local actors to really understand the situation and see where we can be of most use. So sorry, that's not a very straightforward answer, but it's messy, it's difficult, but we have really great people who look at it, so that's good. I see there are two questions in the chat. One about other parts of the country, which I think Allison will answer in a second. The second one, have the efforts to fight COVID-19 eclipse work on other infectious diseases for the time being? Are there still MSF people working on Ebola and DRC? Yes, there are still people working on Ebola and DRC. Unfortunately, I mean, meaning that unfortunately there is still Ebola in DRC. I don't know, Allison, if you have more to say on that, so I can let you answer those questions.
Sure. Thanks, Michelle. So right now we are working in other parts of the country. At the time that we were working in New York City, we also had launched a response in the Navajo Nations and the southwest of the country. Those programs have been handed over as well. We were working in Immokalee, Florida, with migrant worker populations and trying to improve access to testing and also infection prevention and control efforts. Also, again, wherever we were working in the US, we worked very closely with local organizations that knew the communities. We worked with the community leaders themselves. And when we were able to hand over our projects, we did so. The Immokalee project is also closed. We worked in, I think, about 25 nursing homes in Detroit, in Michigan. Again, assisting healthcare staff. So not providing direct, operational support, medical care, but bringing our expertise from other experiences around the world to those caring for people in long-term care facilities. Those projects have also just recently closed, but what we found is we were able to develop a model of care that we are now bringing to Texas, where there are mounting cases, as we know. And so our team is on the ground in Houston, and we're networking, and we're reaching out to local organizations to see how exactly we can help, but our focus there will be in long-term care facilities. So that is a little bit where we've worked in the United States. Again, this is really unprecedented. It really is the first time in our history that we're working in the US, several European countries, also in Canada. We had a small program in Toronto, where I am right now, as well, working with homeless populations. So we're lending our expertise to medical staff and caretakers in hospitals and retirement homes, migrant reception facilities and homeless shelters, and even prisons as well. So the protection of vulnerable populations is among our top priorities, as well as protecting healthcare workers. And so, we're also using our advocacy platforms. We have an access campaign where we're calling on governments and the pharmaceutical industry to ensure rapid production of personal protective equipment, medicines, diagnostic tools, and vaccines, and making sure that during the production of drugs that they're, we ensure access based solely on need. But while we are, there hasn't been a country or a project that hasn't been affected by this virus. MSF is working in 70 countries around the world. Since February, we've launched 148 dedicated COVID-19 projects across 48 of those countries. And we've adapted all of our projects to this new COVID-19 environment. And some of the objectives of our COVID-19 response has been to slow the transmission of the virus, to prevent new outbreaks in health facilities and among the most vulnerable populations, like refugee camps, detention centers. Also, we want to provide care, optimized care for all patients, especially those who are critically ill. And we've been providing palliative care as well for COVID-19 patients in very resource limited settings. It's very important too to communicate accurate health information about COVID-19 to the communities where we're working. We're finding, just like in the United States, and so we're trying through health promotion teams in the communities where we're educating people on what COVID-19 is and how to protect themselves. And really, we're also just trying to minimize the impact of the pandemic on our regular activities as well. So that's kind of our overall approach. But I can also say that to answer the one question about other infectious diseases and Ebola, like Michelle said, yes, we're still very active in the DRC. In fact, I was looking at the numbers of our top countries where we're spending more money on COVID-19, and the DRC is the third most expensive country because it's actually the country that MSF spends the most money every year. So we have extensive programs, whether it's fighting Ebola or maternal health programs or HIV/AIDS programs as well in the DRC. So we're very active there. Yemen is actually the country where we're spending the most due to COVID. And we're also, if some of you tuned in last week, Thursday, we had a Let's Talk COVID-19 discussion with some of our colleagues who are based in Yemen and work specifically on that. So if you didn't catch it, it's recorded and on our website, but that was a really interesting talk to both explaining how we have had to adapt our projects to COVID-19, but also all of these other projects, the ongoing life-saving care that we provide across the country there. I think there's another question here. Are you addressing the psychological issues caused by COVID? For example, I heard that there is an increase in crimes and aggressivity. Michelle, do you have something to add about our mental health work related to COVID?
Yeah, I can speak just very briefly on it. I mean, not so much in terms of crime, though I will say when we were starting to work with the homeless population here, that some staff who had not worked with homeless people before were a little bit concerned about, you know, what can this be and all of this. And I am very happy to report that, you know, a lot of the stereotypes that we have about homeless people are not true, because I mean, yeah, people sometimes got mad at each other or every once in a while an argument, but I think that can happen in any place. That can happen at Starbucks. I mean, people were so thankful and kind, and, you know, we got to know people. They knew our names, we knew their names, and you know, it was a very humanizing thing. I mean, as being a New Yorker myself and taking the subway, and, you know, you get, you know, someone comes on the train and they're drunk or something like this, and everybody suddenly gets really uncomfortable. And it was such a beautiful thing for me to humanize people a bit more. You know, you get to know people as people in a different way, or we were able to, and especially with the showers. And that was really a very meaningful experience for me. I think, you know, with the protests, which we had in New York during our response, and some of the increase in looting and things like that happened here, I mean, I think it's very complex, you know, all of the underlying issues there with that, and then just increasing crime in general. I can't comment on that, but I can say in terms of our experience in New York, I think we really wanted the showers to be a very like calm, welcoming place for people where they could just chill, take a shower. We, you know, had food there. If people wanted something to eat, give them a mask. We had clothes because people weren't able to access clean clothes. Like, it was just a super like chill, very positive environment. They were playing music sometimes. And I mean, we're all human beings, right? People responded so well to that. It was just like, you know, it became part of their routine every day. Stop by the showers, hang out, say hi to the people. So I think that was really nice. And even though that wasn't specifically a mental health intervention, I think it really went a long way for people in terms of mental health. We didn't end up in the US doing something that was more mental health oriented. We looked into it, but it wasn't where we felt like we were best placed or where the needs were the best fit for us. But I think a lot of these other things that we're able to do, you know, supporting the staff of these supportive housing organizations, people were so tense about coming to work. And what does that mean? You know, putting me at risk, putting, you know, my family at risk when I go home, and how do I keep myself safe? And the residents feeling the same, like, how do I stay safe when I'm sharing a bathroom and sharing a kitchen? And coming in and really reinforcing, like, this is how you keep yourself safe, this is how you protect yourself. Does a lot for mental health, right? So it wasn't necessarily a direct mental health intervention, but it really, I think it did a lot for people in terms of helping people feel more secure. There's another question here, Allison, before that one, about how many doctors and nurses work with us worldwide. I don't know off the top of my head.
Yes, I can say that we have 45,000 staff that are working globally, but the breakdown of doctors and nurses specifically, that is unclear, because it's also really important to note that among our aid workers, we have nurses and like Michelle, but as Michelle also in her career has moved to more of a management role. So we hire managers and coordinators and financial, you know, we have budgets, large budgets for all of these projects and that need to be managed. So finance officers, logisticians, you know, we just have a very large group of a staff complement to make up and make possible the work that we do. But so I can say that we're a staff of 45,000 around the world right now. Yeah. I also wanted to address the question from Jean about, you know, the efforts to fight COVID-19 eclipsed work and other infectious diseases for the time being. So it is, you know, important to notice that that MSF's focus is also on maintaining or adapting crucial medical activities like the treatment of HIV, tuberculosis. We're you know, running mass vaccination, measles vaccination campaigns in the DRC, for example. South Sudan is just about to experience a malaria peak, a seasonal malaria peak that we also need to address. So cholera, you know, is existing, so we have to maintain those regular programs as well. But in HIV care, there was a recent model that estimated that a 6-month complete disruption in HIV treatment for a patient could lead to more than 500,000 additional deaths from AIDS-related illnesses. So again, this is something that we're watching very carefully. You know, from the beginning of the pandemic, MSF is trying to mitigate these really serious, what we call like knock-on effects of the COVID-19 pandemic. So we want to maintain the continuity of care of these healthcare services for our patients while we're also responding to the pandemic. We've had to really adapt some of our projects, and for the example in HIV care, you know, we've extended our programs, our community-based programs. So instead of asking our patients to come to the clinic to collect their medications, we're actually going door to door or setting up small mobile clinics so that people can come and receive their medications more locally. And so, and also, you know, checking in on those patients to make sure that they're maintaining their treatment programs, because there is a fear of going to a healthcare facility, just like we're seeing in the United States as well. People are avoiding seeking care because of COVID-19, so we're also trying to monitor that and make sure we continue those vital programs. I'll just look at if we have another Is MSF preparing to be involved in the COVID-19 vaccination process once the vaccine is developed? Michelle, can you help out with this one? Do you know?
That's a great question. I think it will depend on how the vaccine, I mean, I absolutely, I'm sure we would love to be. I'm not sure in the United States, but definitely in other countries we do. Vaccination is a huge part of the work we do in many countries. So I would not be surprised if we get involved in it. But as I'm sure you're very aware or seen in the news, unfortunately, the development of the vaccine is looking like it's becoming very political, not just in the US, but in, across the globe about who's going to have access first to the vaccine. So we'll see how that evolves. And I think our Access to Essential Medicines campaign that Allison mentioned earlier monitors things like that. I mean, this is the whole purpose of their existence, that they really do a lot of advocacy around making sure that the people who need these things the most have access to them. So COVID-19 and a vaccine, and hopefully later a treatment, will be no different with that. And they are monitoring and looking at that really closely. So we'll see how it evolves. But I'm sure that if we have the opportunity to, we will pursue that.
And another one, Michelle, for you, there's one question from Janet about have you any similar programs in the European countries? And yes, and the idea that we really thought that we wouldn't be needed in a place like the US. So I wonder if you also received either pushback or just a big kind of question as to why is MSF operating in the US and in Europe?
Yeah, I'll quote you what a guy from one of these legal, he comes from a legal advocacy organization in New York City that does a lot of legal support for people. And he said, a friend of mine from, wherever asked me, how are things going in New York City? And he was like, well, Doctors Without Borders has had to come and set up showers for homeless people. That's how it's going in New York City. And I think, unfortunately, it speaks to both the severity of the epidemic and the impact on, across the United States, but also, the health disparities that we have in the U.S. And a lot of the system itself is not built to sustain something like this very well. And not everybody has equal access to healthcare in the U.S. And when you look at the numbers and at how COVID-19 has disproportionately affected Black and Brown communities in the U.S., we look at why. It goes back to what I was saying earlier. Okay, more people now have health insurance and things like that, but it's the quality of healthcare that they have access to. Do they have a primary care physician that they're able to see regularly? Can they afford to buy the medications that they need? All of these things. Do they have a life where they can go regularly to doctor's appointments, where they have childcare, any number of these things, or they can take time off of work. So unfortunately, this is where we ended up intervening, and there's no, mystery why we ended up intervening in the places in the U.S. where we did. I mean, we looked to see where we could have the biggest impact, but it really was with a lot of Black and Brown communities, Indigenous communities, whether that was in the Pueblos or Navajo Nation in the Southwest, or working in Detroit, or working in Immokalee with migrant farm workers. This is a lot of the issues that we have here. And I wish we didn't have to intervene either, but unfortunately, a lot of people needed support, and so that's what we did, just like we would anywhere else.
Right, and so Ruth, I think, asked about our response in Beirut. Of course, it's been over a week since the large explosion. I've just linked in the chat there to our latest press release, our program update there. But regarding our response, we do have a large kind of country program, 600 staff on the ground in Lebanon, and so we had teams that were. We have an MSF office in Beirut. I believe there's a video as well through that link that speaks to one of our aid workers who was actually in our MSF office at the time of the explosion. So I would encourage you to watch that. But yes, we did respond in a small way that we could. We focused on wound care, also maintaining or delivering treatment to chronically ill patients, as well as mental health was a large focus on our response so far in Beirut since the explosion there. So that was a situation where there was an emergency disaster, and we already had staff right there on the ground, and so I think they were able to respond right away. But there are also a lot of other actors on the ground there, and so we also want to highlight the other work that we're doing across Lebanon, including work with Syrian refugees as well. So thank you for that question. Just watching the time here, are there any other questions that people would want to speak up instead of right through the chat? Is there anyone that wants to ask Michelle or myself a question?
There was one other question in the chat from Wendy. Do you know what has happened with the homeless population in New York? Have they been able to get people into safe shelters, or is the homeless population on the streets growing? It's still a big issue. I think there is some what they are calling decongestion. I don't really like to call it that when we're talking about people, but anyway, of shelters. So they put some people in hotel rooms so that, because the shelters are congregate environments, people are all together. Usually you're not in a private room or something like that. So social distancing and making sure that you're keeping yourself safe and at a distance from people is difficult. So they've been able to do some things, but the situation is still very precarious for many people. And with the current bills that are before Congress about unemployment and the additional relief people get and all this stuff has a huge impact on people. I mean, I met a guy the first day that we opened the showers, and everyone was waiting for their $1,200 check, and this guy said, I make $55,000 a year, I have a 401k, but I have child support and I have student loans and I lost my house. And he's like, where am I supposed to go? I lost my job, I can't pay my rent, like what am I supposed to do, So I think all these other political things are really, they take a huge impact on individual people. I hope that the leadership of the United States is able to figure some things out and people are able to get the help they need.
Yeah, thank you, Michelle. So I think if there are there any other, well, there's one question from Danielle. Where is your principal headquarters? So as Michelle was mentioning before, we're a bit of a decentralized organization. And so we have these 5 operational centers that manage all of our activities around the world, make those tough decisions on where to go and when to open a project, how to close it. But we do have what we call our international office. So we don't call it our headquarters, but our international office is in Geneva. But in the United States, we have our office that is located in New York City, where Michelle and I both work right now, or in the before times. Yes. So. Yes, thank you so much. Is there one final question before we wrap up? Oh, thank you, Irene. Thank you, everyone.
Thank you so much.
Yes, and I just wanted to thank, on behalf of Michelle and myself and everyone at Doctors Without Borders, thank you to all of you, to World Wings International, for your financial support of our work, but also just your incredible enthusiasm. I've been told by my colleagues on the events team that you are the most enthusiastic group that responds or just even says hello during the Let's Talk COVID events. Whenever there's an event, you're there, you're participating. Last year, so many of you attended are traveling on the road tour. So we feel that. We really appreciate your support in all of those ways. And it's just a wonderful relationship that we have, and we're so grateful. So thanks to all of you, to the board members, to Wendy and Nancy, but to every one of you. And I look forward to continuing to keep you updated, and we'll try to have more of these in the future. So yes, thank you very much.
Thank you.
Before we go, let me just remind all of our members that normally this time of the year, we're doing our international drawing. We're changing it up this year. Jet Wings is coming out. You'll see it in your mailboxes in the next couple of weeks. Look for the blue pieces of paper. There's a letter in it explaining how we're doing it this year, and a matching blue envelope for you to send a check back. So this will be our main global fundraiser for Doctors Without Borders for MSF. And so please, everybody, participate. We're doing it differently. It's all going to be in Jet Wings, and we have just heard how much the money is needed, and we want to have some money in some of those envelopes Michelle referred to. So just watch for Jet Wings. And thank you very, very much for doing this for us. We really appreciate it. And will there be a recap link that people who were unable to join today can see this call? Allison?
Yes. So I started the recording just after Michelle started speaking. So I apologize for that. There will be a little bit, we're missing just the very beginning, but it has been recorded, and Nick, who was helping us earlier today, will be able to send the link to me, and we can share that for those who have missed it. So yeah.
We'll put it on our website too.
Wonderful. That's great.
Data.
Thanks again. You guys do amazing work. Really.
Wonderful. Thank you so much for tuning in. Yes. Everybody take care and stay safe out there.
Bye.
Thank you. Take care.
Thank you. You too.
Bye, everyone.
Bye.